Assalamu alaikum. On behalf of Ahsan Academy, let me welcome you to a presentation on the cardiovascular system. It is the presentation on the covering the general aspects of cardiovascular system, and this is the second part of the presentation. In this presentation, I'll discuss the following aspects: general distribution of the blood vessels, schematic layout of the blood circulation. This is various types of anastomosis and classification, as well as structure of capillaries, nutrition and innervations of the blood vessels, and at all stages I will try to correlate. The blood vessels follow some general rules. The large arteries are more elastic in nature. Their wall contains more elastic tissue, and relatively arteries become smaller and wall become muscular. So medium sized artery and having both elastic tissue as well as muscular tissue in the wall, that is the media, and muscular artery means a smaller artery become totally muscular in nature. The capillaries, the wall become very thin to have the scope to exchange, have an exchange between the blood and the surrounding tissue. The nutrition goes out and waste products are absorbed by the blood of the blood vessels. This takes place at the level of the capillary. There are some mechanisms that controls the flow of the blood in the capillary bed, and those include the arteriole. The very smaller form of arteriole is the metarteriole and precapillary sphincter. There are some shunting mechanism who also controls the blood flow in the capillary bed. Branching pattern, you say these are the larger arteries, this is the heart, this is as ascending aorta, the largest artery arising from the heart, forming the arch of the aorta, going down as a thoracic aorta, entering into the abdomen as the abdominal aorta. So gradually it gives the branch. This is the terminal branch. There are some side branches, collateral branch. So this gradually becomes smaller as the artery branches. So branching become gradually narrow. The branching may be of two types. Collateral branching means on the way artery is giving branch. These are the collateral branch, the side branches. So this is the artery, descending main artery, and giving collateral branch. Even is giving very smaller or larger arteries. And at the end, where this is collateral arteries, and at the end the artery ceases and gives the terminal branches, usually two in number, and they are roughly equal in size, but not always. This one, you see, this is smaller than this one. For the artery, in the gross anatomy, we should know the origin, means how the artery arises as a branch or continuation or like that, the course. Usually we try to compare the position and route in comparison to some important structures. This is called course, and branching you have understood, maybe collateral or terminal branch, and where it actually ceases, ends, that should be understood. So suppose brachial artery, so we should try to understand the origin of the brachial artery, course, branching, and finally where it ends. How that artery originates means begins. So beginning may be as continuation. Suppose this is the road. So this road is crossing one territory, outside this wall one territory, and inside this gate there's another territory. So the road is now up to this level is having one name, then it becomes another identity. So this is continuation, but for better understanding, for better locating, we divide it into with the different names, and this is continuation. Sometimes this road gives some branches, and with the different name. So we can say this is arising from this main road. The same thing happening for the arteries also. It is continuation of the previous one. And here is the example: subclavian artery becomes axillary and brachial. There are some milestones, like this is the gate. Same way, the margin of the bone or margin of some muscles are considered as the point where it continues into another form. So as for example, you can say first rib, or this is the muscle where these arteries are demarcated. This is one artery at the margin of the first rib. This can be as a terminal branch. You see, this is the brachial artery divided into radial and ulnar artery. So radial artery arises as the terminal branch of the brachial artery, but brachial artery is continuation of axillary artery. So in this form, we usually name them as the beginning, and same way we identify the ending. That brachial artery is the origin is continuation, but termination is bifurcation. Usually the artery lies deep and veins are superficial. You see here, you can see the deep part artery, subclavian artery, is deeper in position related to the subclavian vein. You can see the veins are separated into superficial and deep set, but artery lies in the deeper part. Arteries near the joint lies close to the flexor surface. Flexor surface means the joint bends at a point where the surfaces are coming closer. It is the flexor surface where the surfaces are going apart. This is extensor surface. The movement which separates the surface is the extension. So flexor surface is the anterior surface of the elbow joint, is the flexor surface. So you will find that the main arteries are on the flexor surface. The vein also accompany them. You can see this is the artery, as main arteries are on the flexor surface of elbow. These are usually separated from the bone by the muscles or deep fascia or any types of connective tissue fascia. But you see, when this artery come closer, very closer, it produces a groove. Like we will find a subclavian groove on the superior surface of the first rib. This is subclavian groove for the subclavian vein. This is groove for the subclavian artery. So when it comes in very close to the bone, it produces an impression on the bone. Arteries lies close to the corresponding larger single vein. But when the arteries are smaller, they may be accompanied by two veins or even more, and they lies usually by the either side of the artery. You can see this is a small artery and surrounded by three veins, and that veins are also connected by some other small veins. You see, this is an artery surrounded by two parallelly moving veins on either side. This helps in having some or achieving some functions like countercurrent mechanism. These flows are in opposite direction, so countercurrent principles is applicable here. Here this mechanism helps in transmission of the heat, balancing heat and electrolytes. This also, there is active contraction and swelling of the artery, so there is definite pulsation. Swelling causes pressure over the vein, and relapse causes relaxation of the vein. So this way, the venous return is assisted by the position. This is schematic diagram showing some communications between different parts. This is one artery is indicated by the red color, and blue color indicates the vein. This connection is between artery and the vein. You see, the red color area means artery, and there are some connection making the arteries interconnected. Opposite side, you can see the venous end, and some veins are there that connecting the vein. So Connection may be between artery and vein, between artery and artery, between veins and veins. This is known as anastomosis. So joining the vessels by another vessels making loop is called anastomosis. This opens up the alternate way of circulation. Suppose this artery is blocked, then through this blood can flow. Suppose this artery is blocked, so blood will come through this and will go through this to this cover this area. So this route will be opened when this part is blocked. So this is known as collateral circulation, alternate circulation. This is the bypass circulation. This helps to create a bypass channel to maintain the artery supply of that region. There are various types of arterial anastomosis. Arterial anastomosis is relatively more important for the clinical purpose. You see, this is the stomach, and we can see that this is one artery making anastomosis with another artery. So this is one type of anastomosis. You can see one artery is anastomosing, but you cannot identify where is the anastomotic size because they are continuous. So it is an end-to-end anastomosis. End-to-end anastomosis means the two artery opens directly into one another, and this is one example. This one is the right epiploic gastroepiploic artery, and this is left gastroepiploic artery making end-to-end anastomosis around the greater curvature of the stomach. Look at this. This is vertebral artery of one side, another side. They fuse together just under pons to make one artery. This is basilar artery. So this is converging anastomosis. Two arteries unite together to form one. Here the example is formation of the basilar artery by two vertebral arteries. Here you can see this is anterior cerebral artery running parallel to the another one, and they are connected by one transverse artery. This is known as transverse anastomosis. This artery is anterior connection between anterior transverse connection. This is communicating artery. Anastomosis is commonly observed around the joint. Why? You see, this large artery remains in the flexor part of the joint. So whenever we bend the joint acutely and maintain for some time, there will be reduction in the blood flow because of the kinking of this artery at this point. If we maintain for the longer period, the blood flow of this area will be reduced. To overcome that, the alternate channels has to be opened. That's why near the joint we will get more anastomotic channels. Around the stomach we have observed with some region this anastomosis is there. Around the brain to maintain the circulation, collateral circulation, these are the vital organs. So the anastomotic, you see, this is one artery supplying this area, one artery supplying this area independently, but they are having connection. In normal position, each area will be perfused by the corresponding arteries. But if one artery is blocked, then this artery will dilate and meet the blood supplied to this distal part. So this is anastomosis and creating a path for the alternate channel. So function of the anastomosis is this one. This is the angiogram of the lower limb. The large artery is absent here, actually blocked here. So what happened? You see, this is not blocked. This is a normal flow. As often we see that one bridge is under construction. So road, you will get some bypass road. The all vehicles will pass through it and will again reappear on the main channel. So here it is happening. The collateral circulation established by the anastomotic arteries, and again the flow has started to the in the main arteries. So this area is overcome by this one. This is the anastomosis at the knee joint that has opened up the collateral circulation. So perfusion of the distal part of the artery is supplied by an artery which is blocked now. So this main artery is occluded here, we can see. Same thing we can observe here in this case. A tumor in the mediastinum has blocked the superior vena cava. So what happened? Whenever the block is partial, the channels of anastomosis between the branch of the tributaries of the superior vena cava and the tributary of the inferior vena cava has some connection, anastomotic connection. So these channels will be opened, blood will flow over the chest wall and over the abdominal wall to go to the inferior vena cava and reach the heart. So the circulation will be maintained with some features like this one. The superficial veins are dilated. The venous blood is from the superior vena cava going to the inferior vena cava through this channel and reaching the heart. Knowing the direction of the flow, you can understand which one is obstructed. If the blood flows from inferior to superior, then inferior vena cava is obstructed. If blood comes from upper part to lower part, means superior vena cava is obstructed. Flow in the vein can be identified even on the surface. You see, this is one artery supplying this area. So this artery is solely responsible for this one. There is no anastomosis between this. So this is, if obstructed, will be in problem. Solely responsible area, if get obstructed, this distal part will be in problem. It cannot be compensated. This is not an end artery. So one area perfused by certain type of artery which is not having any anastomosis, or having very minute anastomosis that cannot overcome the blockage condition to establish alternate collateral circulation. This is end artery. So collateral circulation is not possible. An end artery may be of two types. Suppose one is not having any anastomosis. So obstruction will cause death of the tissue. No collateral circulation is possible there. This is true end artery. It is observed in the eye. Central retinal artery is true end artery, and if obstructed, causes death of the retinal tissue. On the other hand, if you observe the heart, there is some anastomosis, but it cannot overcome and establish collateral circulation that can meet the demand. So it is insufficient to meet the demand in special condition when one channel is blocked. This is known as functional end artery. So we can explain in this way why the coronary arteries are known as functional end artery. Means there is anastomosis, but it is insufficient and ineffectual anastomosis to establish proper collateral circulation. This type of circulation is also observed in lung, kidney, and in spleen. Best example is heart and brain. Shunting means bypass. Already we know that this is arteriole, and having, why arteriole? Media having two layers of smooth muscle or less. When it is having less, one layer which is rarefied is metarteriole. Suppose this one is metarteriole. When it becomes capillary, a continuous ring of smooth muscle is there at the beginning, a junction between the metarteriole and capillary. This is known as precapillary sphincter. Now we will find in some cases, in some areas, some channels mimics the metarteriole connecting arterial end with the venular end, and blood can bypass the capillary end. This is arteriovenous anastomosis, and this is known as thoroughfare channel. These channels are called thoroughfare channels. So in the capillary bed, we will find the thoroughfare channels. So these thoroughfare channels and precapillary sphincter actually controlling the flow of blood in the capillary bed. So control of the flow, though we say, is controlled by the arteriole, metarteriole, precapillary sphincter, and thoroughfare channel, but these two are the main responsible components, precapillary sphincter and thoroughfare channel. These are numerous in the skin. What is the utility? You see, whenever we face an accident, suddenly if one person face an accident and lose large amount of blood, suppose 1 liter of blood at the spot, what will happen? You see, the vital organs are there: brain, heart, kidney, lung, liver. These should be properly perfused, mean get proper amount of blood. Otherwise, there will be life-threatening conditions. So, skin is relatively less important area. So, body has the mechanism. The precapillary sphincter will contract, arteriole will contract, and thoroughfare channels will be open, leading to rapid movement of the blood from skin to the deeper part. So large amount of the blood that remains in the capillary will be withdrawn from the skin. In this way, the life is saved. And so in this case, where some persons have bleeding, they have pale skin. They develop this paler skin because of the withdrawal of capillary. Redistribution of the blood is the responsibility of the anastomosis. Anastomosis, how it causes? There is artery to artery anastomosis of the various size, various types, so that established collateral circulation. So blockage, in the condition of the blockage, there will be collateral circulation, saving the tissue. True and functional end arteries we have understood. True end artery, because of the lack of that, there is problem with the collateral circulation. Functional end artery, there is collateral circulation, but the possibility of survival of the tissue is less. Vascular shunts, we have understood, this actually helps the blood to bypass the capillary. In many situations, we need redistribution of the blood to the vital organs in special requirement. Then the relatively less important areas, less blood circulation required area, the vascular shunt will be open. This is one arteriole, meta-arteriole, precapillary sphincter, a bit dilated. So blood has entered into the capillary, arteriole capillary, becoming a venous end through exchange of oxygen and carbon dioxide. The blood is shown here by bluish color because this is deoxygenated blood. Nutrition is sucked out by the tissue, waste product has entered, and it is in the larger vessels. So these vessels, you see, the redistribution is required. So precapillary sphincter has contracted. These thoroughfare channels widely opened. So blood is directly going there. Time of flow is reduced. The capillary blood content is reduced. So the large amount of blood is suddenly returning back to the venous circulation and maintaining the blood volume in essential areas. This is called redistribution of the blood. So for the redistribution of the blood, arteriole, meta-arteriole, precapillary sphincter, and thoroughfare channels are responsible. And we have discussed the mechanism, how they are working. You see, these capillaries are a very narrow tube that forms network, and if we take section of the tube, we'll find that it's a simple comprises, the wall comprises of a simple squamous epithelium, means it's a very flat cell with a bit dilated part containing the nucleus. This type of epithelium of the blood vessels are known as endothelium. So this endothelium roll to form a tube. That tube is forming a net-like structure. This is called the capillaries. So these cells are externally covered by a thin layer of non-cellular layer. This layer is called the basal lamina. You see, this is the cells endothelium, pink in color, and this is the nucleus, violet in color, and this blue color is indicating the position of the basal lamella. This capillary forms a very intricate network in the tissue, and this network is known as capillary bed. You can capillaries see the capillary bed of four types: continuous, fenestrated, and discontinuous. Fenestrated one may be with diaphragm or without diaphragm, and discontinuous is also known as sinusoidal capillary. Look at the figure on the left side. This is endothelium, and there is an opening here with a plasma membrane separating the lumens from the outside. This is diaphragm. Here you can see a very narrow channel that is not having any partition wall. So this is fenestration without diaphragm, and this opening is having diaphragm. And one capillary that is having a continuous endothelial wall is the continuous, and discontinuous having some special feature. Let us discuss one by one. This is continuous capillary. Continuous capillary, the endothelium makes tube. The endothelium, adjacent endothelium are very closely opposed and has tight junction between them. Look at this. This is the endothelium. Nucleus you can see, flat cells, and this is the area for the tight junction. So nothing can leak through between the cells, and it requires some control to pass through this cell. So the content cannot pass easily to the outside environment and vice versa. The tight junction maintains the epithelium together as well as prevents leakage. Adhesive joint actually keeps the cell together but fails to prevent leakage. That's why tight junction is between the endothelium of continuous type of capillary. So continuous type of capillary is a good barrier for the diffusion. This is present in the connective tissue, muscle tissue, lung, and also central nervous system. This is central nervous system is very good example, and muscles are the very good examples of continuous capillary. Fenestrated capillary means there is some opening in the endothelium. You see, this is endothelium is continuous, but endothelium contains some openings. That openings may have some partition, diaphragm, or plasma membrane. No plasma there. No cytoplasm is there. So this is the perforations, fenestrated capillaries. So fenestrated capillaries may have diaphragm or may not have diaphragm. There is thickening of the basal lamella near the fenestration. So the control is there on the passage of the substances through the perforation, but the leakage allows more easy transport of the substance between the plasma and the surrounding cell extracellular matrix. So the pathway is relatively easier in case of fenestrated than continuous capillary. This is observed in the kidney, in the endocrine glands, intestine. Here the rapid diffusion is required. In endocrine glands, and hormones are distributed by the blood, so the hormone should easily get inside the plasma, inside the blood vessels containing the plasma, and you see there should be some control. That's why fenestration is there. In kidney, you see rapid filtration is required, and in kidney you will find both type of with diaphragm and without diaphragm fenestrations. In case of discontinuous, that is also known as sinusoidal capillaries and also known as discontinuous sinusoidal capillary. Both words are the same name. So here the endothelium are separated from each other. So there is gap between endothelium. So the lumen is not regular. In case of fenestration, in case of continuous, the lumen is very regular. But here the cells are not adherent, so they cannot maintain the shape. It's beaded appearance is there. Somewhere dilated more, somewhere less dilated. So irregularity is common in sinusoidal form of capillary. The endothelium are separated from each other by gaps, and basal lamella is also not continuous. They are separated in the over the gaps also. That's why there is the leakage is very uncontrolled, and easily plasma, even the content cell, can come out and get back. Liver, spleen, lymph node, and bone marrow, these are the lymphoid organs, as well as the liver contains the sinusoidal capillary, or we can say sinusoids, or discontinuous capillary, anything you can say. To sum up, you see this is the continuous capillary, cells making a continuous layer, tight junction between them. Cells are like continuous but having fenestration, opening in the cell body, and there may be some diaphragm or may not be diaphragm there. Okay, the cells are separated in case of sinusoids or discontinuous capillaries. You see there is gaps. Lumen is irregular, very less control over the passage of substances to and from the capillaries. These are the capillary beds, so that unite together or drain into a relatively wider channel. This is known as venule. You see, arteriole has muscle cord in the media, maybe two or less, but there is smooth muscle. But in the venule, there is no smooth muscle in the wall. Only endothelium like capillary is there, but there is a thick coat of connective tissue over this. The basal lamella is thicker here. So muscle cord is absent, but the diameter may be larger, like arteriole. They drain into the small veins. They have the media. You see, this is artery, and this one is the vein. So adjacent artery and vein. This is very regular, thick wall, but this is relatively thinner wall, larger. Lumen is irregular. So this is having, vein is also having intima, media, and adventitia, but layer distribution is different and structure is different. Subendothelial layer often absent. In the large vein, the tunica intima may be thicker. In the media is not the largest, thickest layer in case of vein. Artery, the media is thickest layer, but in vein, adventitia is the thickest layer. Media, the muscle you see in the artery, form a definite circular layer, and if it is the large artery, then elastic layers are there, circular elastic layers are there. So everything arranged in a circular fashion. But in case of the vein, you will see that the muscles are in bundles. They are separated from each other by the connective tissue. The white areas are shown. The bundles of the smooth muscles are separated by the connective tissue. Tunicata adventitia is the thickest layers in case of vein, and you see this is the thickest of the three layers, unlike artery. Media is the thickest for the artery and more organized in case of tunica media, but in case of vein it is bundles. Connective tissue penetrates between the layers of, between the bundles of smooth muscle. So vein, capillary veins makes the venules. This vein drains into the small vein. This tributaries drains relatively larger veins and forms the medium-sized vein. They accompany the medium-sized artery and they are named. When they flow against the gravity, they contain valves. You see, these are the valves. This is formed by the folding of the endothelium, means lining epithelium containing some connective tissue sheet in it. This permits the one-way blood flow. So against gravity, blood can be flowed because of the presence of the valve. You see, valve divides the vein into small segments. So the pressure over the valve is less. These medium-sized veins are usually named. Let us compare artery and vein grossly. The veins are more in number. They are distributed in superficial and deep set. You see, the veins remaining outside the deep fascia is not superficial veins. So here you will get the artery, but these are very minute arteries, but veins are very large, dilated, even sometimes very, very large and long. But artery is not like that. Artery is distributed in the deeper part, and they are accompanied by the deep sets of vein. Artery corresponds always deep sets of vein. Veins are usually larger in caliber than the corresponding veins. You see, if you compare the brachial artery with the brachial vein is more dilated. The wall is relatively thicker in case of artery, and vein has thinner wall than the artery. Amount of the blood in the vein is relatively larger. About 80% blood lies in the vein, so this is known as reserved blood vessels. Vein has valve, but artery doesn't have valve. At the beginning of the aorta, ascending aorta, there is valve that separates it from the heart. You see, this is a small vein artery, so it is accompanied by more than two or more veins, and these veins are also interconnected. So they follow a parallel route with each other and also make a network around the arteries. So this relation and flow of the blood in opposite direction opens up a one principle that is known as counter current mechanism. So this heat, the difference is balanced here. There is difference in the heat, difference in the content of the electrolytes. So there will be exchange between this vein and artery, and this mechanism is known as counter current mechanism. You see, the artery have a pulsating nature, so they dilates and contracts. So there will be change in volume. So there will be pressure on the veins, and the veins will be squeezed in some part. The vein is divided by the valve into segments. So the one segment when contract is pushed or collapsed, the blood pushes in either direction, and the blood can flow against gravity upward. So the blood cannot go downward because of the presence of the valve. In this way, this position helps in venous drainage against gravity. Same thing is assisted by the contraction of the skeletal muscle. You see this skeletal muscle when contracts, these veins are squeezed. So column moves up, and when the muscle relax, there will be negative pressure. The backflow is not possible because of the valve, so venous blood is sucked above against the gravity. So in this way, contraction of the muscle helps in flow against the gravity, and it is known as musculovenous pump. Sometimes it is known as peripheral muscular pump or peripheral heart. You look at this is the calf muscle. In it there is veins, very dilated veins are there, very large veins are there. So when muscle contracts, muscle bulk is increased, squeezes the vein, and already I have discussed in this way the blood moves against the gravity, and so these muscles are known as peripheral heart, and this is possible because of the presence of valve. This is the muscle contracting, and this valve is breaking the blood into columns and helping to push the blood against the gravity, and blood can flow towards the heart. There is intricate venous anastomosis. You see, superficial veins are there and deep veins are there. They are also connected by some perforating vessels. These are known as perforating channel, perforating veins. They are also guarded by the valve and allows only passage of blood from the superficial to deep. Valves are competent but cannot go back to the superficial region. So muscle contracts, blood will be pushed to the against the gravity towards the heart. It cannot go to the superficial. Same thing happening for the superficial also. They can go to the deep when muscles are relaxing, negative pressure is there. Superficial to deep, blood will flow from superficial to deep. Also pressure over the superficial vein pushes the blood up. If a person remains for a longer period, the different blood problems may arise, will accumulate, and gravity will pull the column of the blood. So vein will lose gradually with the age also lose elasticity. So pressure will cause the dilatation of this type of vein, and there will be incompetence of the valve, leading to accumulation of the more blood, making the blood vessels tortuous. So this tortuosity and dilatation of the vein is known as varicose vein. So this condition is observed in the person who remain standing for a longer time and with the elderly persons. So this varicosity vein can be defined as abnormal dilatation and tortuosity of the vein. This usually occur in the superficial vein, but this can occur anywhere, even in the deep veins. This is most observed in the leg, but it is not only observed in the leg. Anywhere you can see, you can observe this. The blood vessels carry the blood. So they carry the nutrition, oxygen, and so on. So by diffusion, it gets the nutritions. Artery gets more nutrition, so the walls are well nourished. But in case of the vein, the nourishment scope is less. This blood carrying less nutrition, less oxygen. So superficial part close to the lumen gets the nutrition, but deeper part, peripheral part, outer part remains in deficiency. So these part of the wall are supplied by minute blood vessels. Same types of blood vessels are also observed in the arteries who are having very thick wall. So these arteries or vessels of the blood vessels are known as vasa vasorum. So arteries of the blood vessels lies in the outer part, mostly in the adventitia and outer part of the media. These microvessels are observed mostly in the large vein and also with the adventitia of the thicker arteries. Blood vessels contain smooth muscles in the wall. So smooth muscles as autonomic supply. So blood vessels are also having autonomic supply. These are supplying the arteries muscular in nature and also arterial. So whenever nerve is stimulated, the blood vessel contracts. Vasodilatation is a passive mechanism. This is because of the pressure exerted by the blowing bird on the lateral wall. Lateral pressure is perpendicular to the wall, so that causes vasodilatation and release of stimulations. The arteries and the blood vessels are the route through which or that followed by the peripheral nerve plexuses. Autonomic plexus usually follow the arteries supplying different organs. Thank you very much for remaining with the presentation.